Hey, Rick Bukata here. I'm an emergency physician. I'd like to chat with you about a topic that is kind of getting me a little annoyed. I know, and we see all of these articles that are talking about opiate use and opiate use in the emergency department, and that we're getting all of these people addicted. And the fact of the matter is we are not the problem. The amount of opiates that we give out on these periodic intermittent basis is a drop in the bucket, and there's literature to prove it. And I'm writing an article for one of the big EM newspapers that don't go into all of the details of this, but trust me. So basically, we're giving out very little opiates, but everybody's telling us, oh, you got to give out fewer opiates, you got to give it out fewer number of days. The indications, you got to have all 3 legs chopped off before you qualify for an opiate. Here's your Tylenol. It is totally ridiculous. You know, we had this pendulum from oligoanalgesia to what appears to be over-analgesia, and now we're going to go back to oligoanalgesia. Well, the fact of the matter is that physicians, one of our key jobs is to relieve pain effectively. And the fact of the matter is that opiates in the emergency department are titratable. We give people as much as they need based on what the heck's wrong with them. You can't do that with some of these people who are coming up with the opiate-free emergency department. I think that just drives me nuts, the opiate-free emergency department. And where we get into trouble is our prescribing. You know, that's it. We give it out too often. Yeah, no, we don't. Emergency physicians, they're going to be judicious. They're going to use it to the right person. They're going to use the right amount, right duration. Okay. Are there doctors who are kind of off the bell? Yes, there are. They're going to come inside the bell. But my real big concern is that people who need pain medication are not going to get it. They're going to get, here's this pill, that pill. None of those pills work better than the opiates. Oh yeah, I know that there's a study that says that they do. Does that make any sense to you? The fact of the matter is that we need to use them where we need to use them. And it's one of the ethical responsibilities of doctors to take care of pain. But enough of the front end. Why aren't we doing anything on the back end? What do you know about treatment programs for opiate addiction? So they say, oh, all of these people are overdosing and there's 65,000 deaths a year. Well, the fact of the matter is that those deaths are recurring because of fentanyl. When you see the skyrocketing in the deaths, they began in 2013 and they went like almost vertical. Fentanyl is cheap. It's easy to adulterate the heroin with it. And the fact of the matter is there's no way you can titrate it. When people overdose on fentanyl, they can put it in, the needle is still in their arm when they're dead. My nephew had a great friend, close friend. They were raised like brothers. This kid did this recreational kind of thing. He wound up dead, needle in the arm. And that story is repeated by those who know what it's like to overdose on opiates. Heroin, you kind of nod off slowly, that. Fentanyl, dead. I'm concerned that we have an opportunity to start on the back end, treating. There's all of these opiate addicted people. We never talk about treatment. And a lot of these people are seen in the emergency department. What is the treatment? I can tell you what the treatment is. It's called buprenorphine. Buprenorphine is underwritten by the government as the most effective treatment for the treatment of opiate addiction. I have a friend, he's a psychiatrist. He was at the University of Pennsylvania. He's an addiction specialist. He's written 182 papers. I talked to him about a week ago because of my interest in this topic. And he said, by far, opiate addiction is the easiest to treat. By far. And the way you treat it is by giving people buprenorphine. Buprenorphine is an opiate agonist, so you get a little bit buzz, and an antagonist, so you can't overdose. You take more opiates on, you've already antagonized a great deal of your receptors. I don't want to go into the specifics of it. I don't want to go into why you don't need naloxone with it. Buprenorphine requires a special prescribing license, a DEA number. your DEA number gets an X on the end of it. You have to take an 8-hour class to prescribe this stuff. You're only allowed to treat 30 patients a month with it for the first year. For the second year, you're allowed 200, and the year after that, you're allowed, with a waiver, 275 patients a month. There was a program started at Yale, reported in the literature in 2015, where they gave out buprenorphine in the emergency department on people who were addicted, and then set them up with a visit within 3 days at their clinic that also continued to give out buprenorphine. This is something that emergency physicians should embrace. The treatment end of the program, nobody's talking about it, and we can do it. And the fact of the matter is that 80% of the hospitals in this country are nonprofit. They've got money from foundations and other sources to start a program like this. And frankly, we're not talking about people who are shooting up in the parking lot, hanging around your hospital. Buprenorphine is a pill. It's prescribed for 1 month. You can take 1 pill a day. So you come in once a month. Who are these people? These people are in suits. These people are working. These people are maintaining incomes and taking care of their families. This is not the picture that you think. This would be a wonderful thing for hospitals to embrace, to take up the back end. What are we going to do with all these addicted patients? You cannot do talk therapy. It doesn't work, for crying out loud. The literature on this is very clear. So I'm going to write about this, and I'm going to approach our hospital about this, and I'm going to be a pain in the ass about this, because the fact of the matter is that we are not doing nearly enough. The government says we're not doing nearly enough. It's clear that we're not doing nearly enough. And I want you to kind of embrace this idea too. Do a little research. I'm going to do a little writing. I'll tell you, there's going to be a column in one of the big newspapers about it, trying to get doctors to understand that we could be part of the answer. Rather than say people are coming in and they're addicted, and you can say, okay, what are you going to do? I don't know. Here's your Tylenol. Here's your ibuprofen. Come on, please. And the other thing is you say, oh, here's your referral. Yeah, right. So a referral to what kind of program? The vast majority of opiate programs do not use buprenorphine therapy, despite the fact that it will decrease deaths by 50%. The data on it is compelling. So please, think it over. Buprenorphine, initiated in the emergency department, hospital-based buprenorphine program. It'll get you a lot of points. You nonprofits, you're looking for programs to help the community. This one will be one, and you'll see a lot of people who look like normal people who are in fact addicted to heroin or opiates coming out seeking care at your hospital, because your hospital is the most credible provider of healthcare in the community. And if you could offer something like this, sure, it's going to need some support too, the 12-step and all that other jazz, but the core of it is buprenorphine, a tablet a day. Thanks for listening. Bye for now.